In this particular section, we are going to see a new topic on pulmonary hypertension. Pulmonary hypertension, even though it's a very common term used by undergraduates as well as postgraduates, but they don't really understand how many types of pulmonary hypertension is there and what are the pathophysiology behind that and why WHO has classified into these types. At the same time, what is the impact of treatment on those? That's what we're going to see in this particular video. So let us move on. First, what is the definition of a pulmonary hypertension? Definition wise, it's very clear. The mean pulmonary artery pressure, if it's more than or equal to 25 millimeters of mercury at rest. This is what we define as pulmonary hypertension. So those who have seen my basic videos will clearly know the normal mean arterial pressure is somewhere around 10 to 14 millimeters of mercury. If it exceeds 25 millimeters of mercury, we are going to call that as pulmonary hypertension. That's it. So now you might be having a question, what do you mean by a mean pulmonary artery pressure and how to measure that? The best and ideal way to measure the mean pulmonary artery pressure is through the right heart catheterization. That's otherwise referred to as pulmonary artery catheter, which is usually done through insertion of a Swan-Ganz catheter, which we already discussed in the ARDS segment. So anyway, what are the ways to see this mean pulmonary artery pressure? Point number one, the first formula that will tell you it's what is the mean pulmonary artery pressure is that MPAP is equal to 2/3 of the diastolic pulmonary artery pressure plus 1/3 of the systolic pulmonary artery pressure. Clear? So, or I can write 2 times the diastolic pulmonary artery pressure plus systolic pulmonary artery pressure divided by 3. This is also correct. So, just I have modified the equation. That's also, this also is right for the formula for mean pulmonary artery pressure. Or alternatively, you have another formula also, which will tell you pulmonary mean arterial pressure is equal to cardiac output multiplied by peripheral vascular resistance plus pulmonary capillary wedge pressure. So this also will tell you to an approximate extent what is the mean pulmonary artery pressure. So these are some of the formulas. Now you know very well the diastolic pulmonary artery pressure and the systolic pulmonary artery pressure both can be measured easily through the pulmonary artery catheter, because the catheter enters the right atrium into the right ventricle and into the pulmonary artery. So you can easily measure what is the systolic and diastolic pressure in the pulmonary artery. Not an issue at all. But according to this formula, there is something called a peripheral vascular resistance, and how we are going to find out. We all know that this pulmonary capillary wedge pressure also can be easily measured by the right heart catheterization by a process called wedging. Again, we saw this in ARDS. Clear? You also know that pulmonary capillary wedge pressure is an approximation of left atrial pressure, or you can tell it's an indirect measurement of what the left atrial pressure is. So you know this also. All these facts we have known already. But how will you measure the pulmonary vascular resistance? That's the question. So for that, let us move on to the age-old physics, where you are going to have a resistor and you are going to have a current passing through the circuit, and you have the potential difference, but that is going to be the voltage. And this is where your resistance is. That is a resistor, resistance of the circuit. So Ohm's law clearly tells that the potential difference between the two ends is equal to I and R. Resistance times the current, where I stands for the current, R stands for the resistance, and V stands for the potential difference. That is a voltage. So here you can equate all these things in a medical way. For example, here I can tell 2 circuits where you have a resistance in one area, and if this circuit goes to the other end, in the human body, instead of the current, we can actually equate the current to that of the blood flow. What do you mean by your current? Current is nothing but the flow of electrons in physics. It's just a number of electrons that are flowing is what we call the current, sheer number. More the number, more the current. Less the number, lesser the current. Similarly, here you can equate that number of electrons, that is the current, here you can equate to the blood flow in the vessel. Similarly, the voltage can be seen as the pressure difference between the two ends. This pressure difference between the two ends will give you the potential difference, voltage. Like that, here the potential difference, here we are going to see the pressure difference. That's all. This is how you equate the Ohm's law here, and that's how we are going to find out the resistance. According to Ohm's law, resistance equal to voltage by current. Clear? So similarly, here you can equate resistance is equal to pressure difference between the two ends. There it's the potential difference between the two ends. Here we are telling the pressure difference between the two ends divided by current. Here the current is nothing but the blood flow. So for that, let us understand one easy fact. Let us assume this is the right heart, this is the right atrium, and this is the right ventricle, and this is the left heart, and this is the left atrium, and this is the left ventricle. Where you know very clearly the right ventricle is going to give rise to the pulmonary artery on one end, which is going to form a resistance circuit, that is the capillaries in the pulmonary vasculature, which finally becomes a pulmonary vein, which is going to enter the left atrium. So the pulmonary vein is another end of the circuit, whereas the pulmonary artery is the another end of the circuit. You know very well the pulmonary vein is going to be connected to the left atrium, which means the pulmonary venous pressure means it's nothing but the left atrial pressure. Like how your right atrial pressure means it's the central venous pressure. Similarly, the pulmonary venous pressure is nothing but the left atrial pressure. We know very well this left atrial pressure you can measure through pulmonary artery catheter, that is your Swan-Ganz catheter, through a wedging process called pulmonary capillary wedge pressure, which is otherwise referred to as pulmonary artery occlusion pressure. So which means this is the one that's going to indirectly tell you what is the left atrial pressure or the pulmonary venous pressure. Fine. Now how to find out the pulmonary vascular resistance at this point? Because the lungs are located at this zone only, and they are the ones that are oxygenating the blood here. So which means we are going to find out the pulmonary vascular resistance at this point. So applying this formula, the pulmonary vascular resistance will be equal to the pressure difference between the two ends. That is the potential difference, voltage. So where you can clearly tell on this side it's the mean pulmonary artery pressure, minus on the other side the difference is pulmonary capillary wedge pressure, divided by, obviously you know, it is the pulmonary blood flow. Where again you can rewrite this formula telling pulmonary vascular resistance is equal to mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by the cardiac output, because the pulmonary blood flow must be equal to the cardiac output. As simple as that. Whatever that is coming from the other side, it should be equal to the cardiac output. That's all. And very importantly, it's very important hemodynamics also to understand. If somebody asks you what is the function of the right ventricle, I told you this in the pulmonary embolism topic itself. It is to maintain the preload of the left side. So what I'm trying to tell is whatever is going to through the pulmonary circulation into the left ventricle only, that only will be coming as cardiac output. Which means you can indirectly tell the pulmonary blood flow is the one that is going to come out from the left ventricle as cardiac output. So you can equate that into the cardiac output. Very simple. So this is the formula for pulmonary vascular resistance. But by this formula, you are going to find out the pulmonary vascular resistance in Wood units. You are going to find out the pulmonary vascular resistance in the Wood units. But the standardization is to measure the pulmonary vascular resistance in dynes per centimeter power minus 5. So this is a standard formula, this is a standard unit that you have to follow. So to do this, I can again rewrite pulmonary vascular resistance is equal to 80 multiplied by the same formula. That is MPAP minus pulmonary capillary wedge pressure divided by cardiac output. So this will give you your answer in dynes per centimeter power 5, which is the preferred unit in the current world right now. So this is the pulmonary vascular resistance. Clear? This is the formula. So easy to find out. Everything you can have all the data now. You have the MPAP through the right heart catheterization, you have the PCWP also through right heart catheterization, you have the cardiac output data also through the right heart catheterization. That is why to find out all these things, right heart catheterization is going to be the gold standard. That's pulmonary artery catheter. Clear? Similarly, you can actually find out the systemic vascular resistance also. Systemic vascular resistance is very simple. You know, your aorta comes out and the major vessel arterial system, which again forms a resistance circuit in the periphery, which will again form great veins, which is going to enter the right atrium, right? Great veins which are going to enter the right atrium. So which means you know very well, the pressure difference is what is the key here. Here, this is the pressure on one side, that is the mean arterial pressure. And obviously, the venous pressure you can easily find out, which is the right atrial pressure on the other side, that is the central venous pressure. We know that already. Together with that, this is the resistance circuit. And you know, the flow of the blood will be the systemic blood flow here. So you can also write that your systemic vascular resistance will be equal to the pressure difference. What is the pressure difference? That is the mean arterial pressure minus central venous pressure divided by, obviously, the systemic blood flow will be equal to the cardiac output. That's all. Suppose if you want in dynes per centimeter power 5, multiply by 80 as an option. Simple. This is what is going to be the systemic vascular resistance. What they will tell is, mean arterial pressure and pulmonary capillary wedge pressure have a lot of difference. Mean pulmonary artery pressure and pulmonary capillary wedge pressure will have a lot of difference. But your mean arterial pressure and central venous pressure is huge. Like the difference is huge. It's way apart. Like for example, the mean arterial pressure is somewhere around 85 to 110. Average is around 95. That's the normal mean arterial pressure. The central venous pressure will be only 2 to 6 millimeters of mercury, which means central venous pressure is very, very negligible. According to your differentials, you study in your 9th standard or 10th standard mathematics, where there is something called a differential calculus, where you tell something called infinitesimally small. If it's infinitesimally small, you can exclude that fact, isn't it? So like that, your physiology textbooks will give systemic vascular resistance is equal to mean arterial pressure by cardiac output. Remember, only if the CVP is negligible to eliminate. For example, the CVP itself is 20-25, you cannot eliminate that. And MAP is only 60 or 50, it becomes almost half of the MAP and you cannot eliminate that. So in a normal physiology, CVP can be excluded because it doesn't contribute that much to the resistance, to the equation in fact. So you can rewrite the equation as systemic vascular resistance equal to MAP by cardiac output, and you can multiply by 80 if you want in dynes per centimeter power minus 5. So this is the resistance formulas. By this fact, what will be the normal resistance? So you can tell in Wood units also, you can tell in dynes per centimeter power 5 also. So the normal pulmonary vascular resistance in Wood units is somewhere around 0.25 to 2 Wood units, whereas in dynes it's going to be somewhere around 20 to 160. But you can simply write as less than 250 must be the normal, or some books will give less than 240. That doesn't make a big deal. Similarly, systemic vascular resistance normal must be somewhere around 8 to 16 Wood units, which means it's somewhere between 800 to 1400 dynes. So this is the usual normal systemic vascular resistance and pulmonary vascular resistance. So this is how you have to understand. Clear? So these are the normal things. So with this, we can move on to the other understanding. So I hope you have understood how to measure the pulmonary vascular resistance, systemic vascular resistance, and all this stuff. With this, we can move on to the etiology and the classification especially. So how the WHO has classified the pulmonary hypertension. So let us see the classification. So this is the WHO classification which I am going to talk about, which was currently called as Dana Point classification, because this is the place where this consensus took place last. So that's why it's called a Dana Point classification also, or a Dana Point WHO classification. So how they classify? They classify pulmonary hypertension into 5 types. One is type 1 pulmonary arterial hypertension, type 2 pulmonary venous hypertension, or it's due to left heart disease, type 3 it's due to lung disease, and type 4 pulmonary hypertension due to chronic thromboembolism, and type 5 is miscellaneous and other causes which are multifactorial and you cannot put into particular area. So this is how they classified. So let us see what is the impact of this classification and why this is important. You all know, again I'm going to draw the same diagram like Captain America. I can do this all day. So I'm going to draw the same diagram once again for a better understanding. So let us put, this is the left atrium and the left ventricle, and this is the right atrium and the right ventricle. You know that you have the pulmonary artery that is going to form the capillary system and the resistance circuit in the pulmonary area. And finally, you get the pulmonary veins that are going to join the left atrium, which are 4 in number. Simple. Now, you have the lungs here that are trying to oxygenate your blood on the way. This is the pulmonary blood flow that is happening. Clear? So, according to WHO, where is the problem in type 1 pulmonary hypertension? In type 1 pulmonary hypertension, the problem is in the pulmonary vessels, pulmonary arterial vessels, where they will go for vasoconstriction, platelet aggregation and thrombosis, platelet aggregation and thrombosis. At the same time, they are going to go for obliteration. Clear? So, which means the site of resistance is in the pulmonary vasculature, where blood finds very difficult to move out of this area. The entire pulmonary vasculature will be behaving like this. So this is what we refer to as typically a type 1 pulmonary hypertension, or a pulmonary artery hypertension, or otherwise called as primary pulmonary artery hypertension. Simply it's called PAH, that's all. Then type 2, as I told you, it's due to left heart disease. This is the type 2 pulmonary hypertension. This is due to left heart disease. Left heart disease means the disease could be in the ventricles, or disease could be in the valves, or disease could be in the atrium also, but whatever may be the fact, that will result in poor ejection of cardiac output from the left side, which means there will be passive congestion and accumulation of the, because the failure of the pump, backflow will be there, passive congestion and accumulation of the blood in the pulmonary veins, which will result in pulmonary venous congestion. You know very well, already, there are a lot of people waiting here to pass down into the left side and to get ejected. That is not happening. How can you expect the circuit to be resistance free? Which means the pulmonary blood flow will not happen and it will be reduced to a great extent because the resistance is at this area, which means they cannot move forward. That's the reason. And slowly the congestion will leak and it might start entering into the capillary system and it can reflect as mean pulmonary artery pressure elevation called as pulmonary hypertension. So this type of left heart disease causing pulmonary, reflecting as pulmonary hypertension is what we refer to as type 2 pulmonary hypertension. Lot of causes are there for this. Similarly, what is type 3? Type 3 pulmonary hypertension is due to lung disease. I told you, suppose if there is a lot of areas in the lung which are not ventilated properly, let us assume these all areas in the lung are not ventilated, which means so many areas in the lung are defective, they are not ventilating. You know very well, if they are not ventilating and they don't have sufficient oxygen in the alveoli, this pulmonary circuit, capillaries and the blood vessels in the pulmonary system is going to go for a phenomenon called reactive hypoxic pulmonary vasoconstriction. That's what we already discussed in detail in the basic section in the form of something called Euler-Liljestrand mechanism. That's called Euler-Liljestrand mechanism. So this is what is going to happen here. Euler-Liljestrand mechanism and hypoxic pulmonary vasoconstriction. So because of this hypoxic pulmonary vasoconstriction, the blood finds very difficult to move out of this vasoconstricted area, which means again the site of resistance is the lungs itself here. Clear? So that's why this is called a type 3 pulmonary hypertension or pulmonary hypertension due to chronic lung disease. And you have a type 4 pulmonary hypertension where it's a very simple fact that there is going to be a emboli. One or two, many multiple emboli also can be there. So this is what we refer to as a type 4 pulmonary hypertension, which is also referred to as chronic thromboembolic pulmonary hypertension, CTPH, chronic thromboembolic pulmonary hypertension. So if you get, this is because the resistance is here, again, that is because of the embolus. Something, it could be, remember, it could be thrombus or it could be embolus, can be a non-thrombotic source itself, like tumor, foreign body also, or even a parasite can produce embolus like this. But let us discuss about the fact later on. So that's called a chronic thromboembolic pulmonary hypertension causing the pulmonary hypertension here. So we have 4 different types now. The actual pulmonary artery is going for obliteration called as pulmonary artery hypertension. Second is your left heart disease causing pulmonary hypertension. Third is lung disease causing pulmonary hypertension. Fourth is your thromboembolic type of pulmonary hypertension. Then you have fifth type, which will not fit under anything. Fifth type generally is called as miscellaneous type or type which is having multifactorial causes, which cannot be put under a particular type 1, type 2, type 3 or type 4. That's called a miscellaneous, type 5. So let us see how will you treat. Type 5, leave it because the treatment is going to be depending on what the cause is. But type 1, type 2, type 3, type 4, we have a defined etiology and defined pathophysiology so that we can treat in a defined way as well. So whenever you have a type 1 pulmonary artery hypertension, means it is due to vasoconstriction and platelet aggregation and obliteration of these vessels. So there should be something, some agent that can reduce all this process. How you can reduce all this process? By giving vasodilators that have properties of vasodilation as well as they can reduce platelet aggregation. Let us see what are those later on when we discuss about the treatment. So vasodilators are going to be the mainstay. But remember, the vasodilators are not going to work for type 2 pulmonary hypertension. At least, in fact, we don't have that much evidence because the vasodilators we are talking here are the pulmonary vasodilators, not the systemic vasodilators. There are systemic vasodilators, there are pulmonary vasodilators, there are pulmonary and systemic vasodilators. But the vasodilators we are talking here is about predominantly the pulmonary vasodilators. That's what we're talking about. So if you give a pulmonary vasodilator, what will happen? Suppose in a type 2 patient, you are giving a pulmonary vasodilator. So you are trying to dilate the caliber of these vessels. And because of dilation, you are going to reduce the resistance here. Because the resistance is reduced, the blood is going to move in an accelerated fashion towards the left side. If it goes in an accelerated fashion towards the left side, actually you are trying to increase the pulmonary blood flow, but there is actually a lot of congestion going on in the pulmonary veins. So increasing pulmonary blood flow is not going to help you. Already there is a lot of congestion which is unnecessarily going to put a lot of, workload on the left side of the heart, which is already failing. So this is going to worsen the left heart failure and not going to help you in any way. So that is why vasodilators have a very, very poor response for treating a left heart disease. You don't have sufficient evidence to treat the left heart disease vasculitis. In fact, certain trials are telling it actually worsens the left heart disease by increasing the preload and increasing the flow across the pulmonary vessels. So it's not going to work. So the only treatment for type 2 disease will be to correct the problem, correct the left heart disease. That's going to be the main treatment aspect for type 2 pulmonary hypertension. Similarly, type 3 pulmonary hypertension, there is no point in correcting the left heart disease, there is no point in giving a vasodilator. The main thing here is to correct the underlying lung disease. Even the vasodilators work to a little extent because here it is due to reflex vasoconstriction, and nifedipine, what you are giving for type 1 pulmonary artery hypertension, might work a little bit here, but the basic problem is the lung disease. So correct the underlying lung disease, and the treatment of that is going to be the key. Or oxygen therapy might be very, very helpful. In any case, oxygen therapy might be helpful here also, type 3 also. Oxygen therapy may be helpful in type 1 also, because oxygen will produce inhibit the hypoxic pulmonary vasoconstriction, so that it might do a little bit of vasodilation, so that you might have a reduction of the resistance in that area. Apart from that, final resort will be lung transplant only, because if the lung disease is uncorrected, this hypertension will be uncorrected. So lung transplant will be the final resort. So these are some of the options for treating the type 3 pulmonary hypertension. Type 4 pulmonary hypertension, it is due to chronic thromboembolic pulmonary hypertension, which means I am going to treat with anticoagulation only. Clear? So this is the idea. So this is how you are going to analyze the classification form and treat the type of pulmonary hypertension in an appropriate way. Basically, you can classify into pre-capillary and post-capillary pulmonary hypertension. This is the right heart catheterization based classification, pre-capillary and post-capillary. Pre-capillary means before the formation of capillaries, post-capillary means after the formation of the capillaries. Pre-capillary, classic example for a pre-capillary pulmonary hypertension is type 1. Classic example for a post-capillary pulmonary hypertension is type 2 pulmonary hypertension. Clear? But there are some other types also which come under pre-capillary, like type 3 and type 4. That will also come under pre-capillary only usually. But remember, this type 5 can be either pre-capillary or it can be even post-capillary. That's why we are putting under miscellaneous type, because you cannot fit them under a proper category because they are multifactorial causes. So what is going to be the differences between all this? The first one is the mean PAP. Mean pulmonary artery pressure will be more than 25 in both these conditions. That's why it is called as a pulmonary hypertension in the first place. Then your pulmonary capillary wedge pressure comes into 4, where it's going to be less than 15 in case of a pre-capillary, whereas your pulmonary capillary wedge pressure is going to be more than 15 millimeters of mercury in case of a post-capillary pulmonary hypertension. Because it's due to left heart disease, definitely left heart disease, the pulmonary capillary wedge pressure will be elevated, because in congestion, left atrial pressure will be high. Then you have something called a transpulmonary gradient, which I didn't tell you here. Here the transpulmonary gradient will be increased, that will be more than 12 usually. Here the transpulmonary gradient will be normal, that is less than 12. So what do you mean by transpulmonary gradient? It's very simple. Let us move on to the basics. Transpulmonary gradient is nothing but this thing, mean pulmonary artery pressure minus pulmonary capillary wedge pressure. It is like the voltage in your Ohm's law. Voltage is the potential difference, whereas transpulmonary gradient is the pressure difference. That's all. So transpulmonary gradient by definition must be equal to mean pulmonary artery pressure minus left atrial pressure, that is the pulmonary capillary wedge pressure. So what will happen in a pre-capillary pulmonary hypertension? In pre-capillary, take a typical example, that is type 1, where the mean pulmonary artery pressure will be very high, but the pulmonary capillary wedge pressure will be normal, because this is not due to left heart disease. Now why the hell the PCWP should be elevated? So it will be normal only. So here, since this is elevating and this is normal, your pre-capillary cases, the transpulmonary gradient will be very, very high. Whereas in post-capillary pulmonary hypertension, typically due to left heart disease, means in this patients, the mean pulmonary artery pressure also will be very high, and the pulmonary capillary wedge pressure also will be very high, which means both are very high, and the difference is going to maintain in the normal range. So this is a very important analysis that you have to know. And similarly, if you calculate the pulmonary vascular resistance here, it will be extremely high, whereas here the pulmonary vascular resistance is highly variable. It can be normal or it can be even elevated. So I'll tell you, I'll discuss about that when we are discussing about the diagnostic tools. That time we'll discuss. So these are the difference between a pre-capillary and a post-capillary pulmonary hypertension. And I told you the causes also. Now, let us go to the actual etiologies. After knowing all this, let us move on to the actual etiologies of pulmonary hypertension. Pulmonary hypertension has different types of etiologies. Among the same types itself, we have a lot of etiologies. For example, type 1 is the biggest actually. Type 1, that is a pulmonary artery hypertension, or you can call it as primary pulmonary artery hypertension. You know the characteristic features of that, but let us see the causes. What all will be the causes? Cause first one we call it as IPAH, that's called idiopathic pulmonary artery hypertension, which typically results only in mild increase in pulmonary artery pressures, a reasonably okay prognosis compared to other causes of pulmonary hypertension. Typically common in males compared to that of the females in the ratio of 2:1, and the average age where the patients will be affected is approximately 36 years. Very rare, the incidence is only 1 to 2 cases per million itself. So it's very, very rare incidence. So idiopathic pulmonary artery hypertension. Then second one, you have another type of pulmonary artery hypertension called a familial pulmonary artery hypertension called as FPAH. It's called a familial pulmonary artery hypertension, where typically it is due to a genetic mutation called a BMPR2, that is bone morphogenic protein receptor 2 mutation. Because this bone morphogenic receptor 2 is linked to a TGF-beta signaling pathway. So there is disruption of the TGF-beta signaling pathway, and that is the reason you result in fibrosis and obliteration of the pulmonary vasculature. Or you might even result in damage to the endoglin pathway. Or endoglin is one of the genes that is one of the important cellular components. So endoglin, when it is affected also, you might result in primary pulmonary hypertension. This familial pulmonary artery hypertension. So this is there. Then number 3, you have another condition called associated pulmonary artery hypertension, that's called APAH, where you are going to have a lot of associated conditions. The first important condition is the CTD, that is continuous tissue disorder. Lot of continuous tissue disorders may result in associated pulmonary artery hypertension. What are they? The first is always you have to note about the CREST syndrome. This is going to be the exam question. CREST, always CREST in scleroderma, limited sclerosis. We will discuss in rheumatology in detail. Then you have rheumatoid arthritis, SLE, Sjogren syndrome, polymyositis, mixed continuous tissue disorder. Lot of conditions can produce this type of primary pulmonary artery hypertension. That is coming under something called APH, associated pulmonary artery hypertension. Then you have congenital left to right shunts. The classic left to right, this is because of increased pulmonary blood flow. Because of that, there will be reactive changes in the pulmonary artery, which is going for obliteration and fibrosis. So, what are the classic left to right shunts? The moment I call left to right shunts, you have to immediately tell 3 things: VSD, ASD, PDA. These are the classic left to right shunts that will result in increased pulmonary blood flow through the pulmonary artery. Fine. Then you might get in another condition called a portopulmonary hypertension. Portopulmonary hypertension, where it is due to, because it happens in end-stage liver disease. In end-stage liver disease, what really happens is lot of vasoactive substances and vasoconstricting substances that has to be filtered by the liver doesn't get filtered, which means they are freely circulating in the blood without getting detoxified or filtered in the liver. Because of that, they will go and cause severe vasoconstriction in the pulmonary vasculature and especially the pulmonary artery, resulting in portopulmonary hypertension. You always have to note that is not equivalent to the another disease called hepatopulmonary syndrome. Hepatopulmonary syndrome is a separate condition where you are going to result in vasodilation, and because of that you will have a problem. Portopulmonary hypertension is a condition that causes vasoconstriction, and both can happen in end-stage liver disease. So how you will differentiate between these two, we are going to see in the hepatology section. But anyway, right now understand portopulmonary hypertension is the one, not the hepatopulmonary syndrome. Clear? Hepatopulmonary syndrome will come under type 1 respiratory failure in shunt formation, not portopulmonary hypertension. Now finally, you have other conditions like HIV called as HIV associated pulmonary hypertension, and you have another condition called drug induced. A lot of drugs can cause, especially your anorexic drugs. Anorexic agents can produce, and similarly L-tryptophan is another drug that can also produce pulmonary artery hypertension. These are some of the conditions which can result in associated type of pulmonary artery hypertension, which is a type 1 pulmonary hypertension again. Then you might get in other conditions where you have a condition called pulmonary veno-occlusive disease. That's called the pulmonary VOD, pulmonary veno-occlusive disease, like sinusoidal obstruction syndrome we saw in bone marrow transplant. This is also similar to that. So that is the reason causes for this is going to be the bone marrow transplant, allogenic hematopoietic stem cell transplant once again. It doesn't only cause obstruction of the sinusoids in the liver, it can also cause obstruction of the pulmonary veins. pulmonary veno-occlusive disease. Or it can happen with a lot of chemotherapy agents like bleomycin, busulfan, and other chemotherapeutic agents also may cause this pulmonary veno-occlusive disease. Then you have a final condition called pulmonary capillary hemangiomatosis, very, very rare entity. Pulmonary capillary hemangiomatosis. Apart from that, so many other varieties are there in the newborns that we are not discussing right now. Clear? So these are some of the examples of type 1 pulmonary hypertension. Then you have type 2 pulmonary hypertension. We know that it is due to left heart disease. We know this is due to the left heart disease. And the left heart disease can be ventricular, or the left heart disease may be valvular, or the left heart disease may be just atrial. In the ventricular, you know, it could be either due to a systolic dysfunction also, or it could be due to a diastolic dysfunction also. So which means whatever may be the fact, it is due to the left heart disease. That's all. Type 3 pulmonary hypertension, we know very well it is due to the underlying chronic lung disease. That is the reason. Chronic lung disease causing reactive hypoxic pulmonary vasoconstriction. This results in increased resistance and pulmonary hypertension. So you can divide into common causes and little bit of rare and uncommon causes. Common causes, you know, these are extremely common, like COPD, sleep apnea, ILD. Rare causes like developmental abnormalities, like kyphoscoliosis, a lot of developmental problems in the chest, or it could be due to chronic alveolar hyperventilation. Means typically it happens in a MND or a ALS patient. Classic examples, or a poliomyelitis who is badly affected. So they will go for chronic alveolar hyperventilation, and because of that low ventilation, they'll go for reactive pulmonary vascular vasoconstriction, and because of that they go for high resistance and pulmonary hypertension. Or it can be due to chronic hypoxemia. The best example for that is any condition can produce, but chronic mountain sickness, I can tell. Where you have discussed about this fact in the, I think in the second video of the pulmonary medicine lecture. Oxygenation principles. There we have discussed high altitude related problems. There I have discussed on chronic mountain sickness as well. So type 3. And type 4, you know very well, it is due to embolism. The hypertension is due to embolism. Even though it's called chronic thromboembolic pulmonary hypertension, it may not be really due to a thrombus. So that's why I am splitting into two. One is a thrombotic and second is non-thrombotic embolus. Thrombotic embolus and second is a non-thrombotic embolus. Thrombotic embolus, you know very well. It can affect either a large vessel or a medium vessel or even a small vessel. Or it can affect a proximal vasculature or even a distal vasculature. Anything it can affect. So this is a thrombotic. Non-thrombotic per se means the embolus is not originating from a thrombus, not from a clot. Here the ball of embolus is from a different structure. For example, it could be from a tumor, it could be from a foreign body, or it could be some parasites like schistosoma also. So a lot of things are there. So that's what you have to know. It could be either thrombotic or non-thrombotic, but obviously the thrombotic is going to be the most common. That's chronic thromboembolic pulmonary hypertension. And finally, you have type 5. That is miscellaneous, which will not fit under anything. So what are the important conditions? Some important conditions are there, like sarcoidosis, whose mechanisms are not clearly understood. Sarcoidosis, how they produce pulmonary hypertension, Langerhans cell histiocytosis, then lymphangioliomyomatosis, schistosomiasis, multifactorial, that's what I'm trying to tell, and end-stage renal disease, CKD patients. Or the process could be due to extrinsic compression of the pulmonary vessels. Compression of the pulmonary vessels from the outside, not from the inside. So for example, a lymphadenopathy, especially mediastinal lymphadenopathy or fibrosing mediastinitis, which is simply referred to as mediastinal fibrosis, fibrosing mediastinitis. Or it could be due to histoplasmosis, or it could be even due to a radiotherapy to the chest that might cause all these problems. Finally, there are some miscellaneous causes which produce pulmonary hypertension by unknown mechanisms, like thyroid disease, glycogen storage disease, Gaucher's disease. There is a disease called hereditary hemorrhagic telangiectasia. HHT. We have discussed in detail about this disorder also. Then sickle cell disease, chronic myeloproliferative neoplasms, or you can simply write as myeloproliferative neoplasms. Then after splenectomy, so many conditions are there where mechanisms are clearly not understood. Clear? So these are the different types. In this, I believe the most important will be the CREST syndrome, if you want to pick up only one. In this, you can tell anything because it's just left heart disease. In this, the most important will be the ILD, OSA and COPD. In this, the thrombotic component will be the most important. In this, it will be the sarcoidosis that will be the most important in this. Miscellaneous, that is going to cause a pulmonary hypertension. So, lot of stuff is there, but we have discussed the causes very elegantly and very neatly. That's why I told you, the diagnosis of this primary pulmonary artery hypertension can be only made out by right heart catheterization. Very simple. Without that, you cannot make a diagnosis of type 1 pulmonary hypertension. Take in heart. It's very, very important thing. And second thing, treatment will be predominantly vasodilators and agents that reduce the platelet aggregation and vasoconstriction. Type 2, you know very well, the main diagnostic investigation will be echocardiogram, where it will clearly show the left heart disease. Plus or minus, you might be needing the right heart catheterization to rule out the coexisting type 1 pulmonary hypertension, which we'll discuss in some time. And the treatment will be to propel the blood from the left side, which means it's to improve the cardiac function, left heart function. That's the main treatment here. In type 3, you know, it is completely due to some lung disease. Here, the diagnosis will be made using certain set of investigations, but the most important is going to be the HRCT, which is going to show lot of, disorders that can result in this parenchymal lung disease causing this type of hypertension. So, HRCT is the major stay of diagnosis of type 3 pulmonary hypertension, where you can add additional investigations like pulmonary function test or investigations like polysomnogram to find out the OSA, obstructive sleep apnea. So, you can use all these things, and the treatment will be only to improve the lung function. Adjunctive treatments are there, like you can use to treat with oxygen therapy, or you can do a lung transplant, or treating the underlying lung disease with bronchodilators in case of COPD, steroids. So, whatever you want, you can give. So, that is the treatment. That is whatever the treatment may be, it is to improve your lung function. In type 4, the main diagnostic yield will be on CT pulmonary angiogram, plus definitely you have to do VQ scan. Because please understand, CTPA can see only medium and large vessels. This we have seen already in the pulmonary embolism chapter itself. VQ scan is the one that can see smaller perfusion defects also. Small vessels also can be analyzed by this VQ scan. That's why VQ is very important here. Treatment predominantly, most of the time, it will be anticoagulation. And remember, anticoagulation can be added here also. This one important treatment is there. Vasodilators, not only the vasodilators, you will give oxygen as an adjunct. You can give anticoagulation also in these patients. Why anticoagulation may be indicated here? That is because if you take the type 1 pulmonary hypertension, there will be a lot of stasis of the blood in the right ventricle and the pulmonary artery. And if you take the mechanism, I would have told, it is not only vasoconstriction, it's also platelet aggregation and thrombosis that is also happening in type 1 pulmonary hypertension, right? Because to prevent the platelet aggregation and thrombosis, anticoagulation is, even though not proven perfectly in all the trials, but still certain trials are showing at least marginal benefit. So, in patients who are having some cardiac risk factors, like I'll tell you what are they, like RV dilatation, RA dilatation and all, still you can give anticoagulants here also in type 1. So, that's why it's overlapping treatment will be there, don't get confused. And typically type 5, we don't know how to treat because it depends on what is the cause. For sarcoidosis, you can give steroids and other immunosuppressants. Depending on what the cause is, you can treat them accordingly. So, that's it. So, these are the different analysis of types of pulmonary hypertension. These are the different etiologies of pulmonary hypertension. But right now, we are going to go into the clinical features of pulmonary hypertension. What will be the clinical features? Remember, all the clinical features that are explained here will usually go towards classic type 1 pulmonary artery hypertension. But you can equate this to other pulmonary hypertension types also. But whatever we are going to tell now, it will apply perfectly to the type 1 pulmonary artery hypertension. That is where it is classic. It is the pulmonary hypertension that we are going to talk about. But you can equate this and extrapolate to other types as well. So what are the different clinical features that you're going to get? Typically, the symptoms what they're going to get are 2 to 3 different features you will be having. The first feature is the dyspnea and shortness of breath. Second feature is syncope. Syncope is very notorious in pulmonary hypertension. Very, very common in syncope, this particular feature. And they might have a chest pain also. That is because of right ventricular hypertrophy and ischemia. Why right ventricle goes for hypertrophy? In pulmonary hypertension, you know that the blood finds a very difficult way to move out of the right ventricle. So obviously, the right ventricle should equip itself by getting hypertrophied because its force of contraction should increase. That is why right ventricular hypertrophy, and this right ventricular hypertrophy is due to pressure overload. And this is a very common phenomenon in pulmonary hypertension. Clear? So these are the things, and all these things are very categorically going to happen during exertion. So exertional dyspnea, exertional syncope, and exertional chest pain due to right ventricular ischemia. All these things are extremely common. And you can also see overt signs of right ventricular failure or right heart failure like ascites, pedal edema, hepatomegaly and jaundice, and elevated JVP. All these things you might be seeing in the patient with the pulmonary hypertension, chronic long-standing pulmonary hypertension. That's what we're going to call it as cor pulmonale. That is due to underlying lung disease causing right heart failure. Then what will be the signs? Examination findings. What are the signs and examination findings you can look for? Number 1, you can see loud P2. This is what in exam you will be regularly asked, loud P2, loud closure of second, loud sound in the second component S2. That is because of the very loud and faster closure of the second component of the S2, that is P2. And second thing, not only the loud P2, you will have narrow split P2 also. Narrow split second heart sound also. That is because you have 2 components in second heart sound, that is A2 and P2. What's going to happen is because of pulmonary hypertension, the valves tend to close very faster because the A2 and P2 are split because of the differences in the duration of blood flow through the valves. So because the systemic vascular resistance is high, A2 closes faster. Because the pulmonary vascular resistance is low, the blood flows through a longer time through the pulmonary valve, so the P2 closes later. That's why you have A2, P2 like this. Supposedly, if the pulmonary vascular resistance also becomes almost same as that of the systemic vascular resistance, the A2 and P2 will become superimposed because both have the same resistance and both close faster now. So you will result in a very narrow split S2 only. It's a very important sign of a pulmonary hypertension, especially a chronic pulmonary hypertension. You might see a parasternal heaving. Parasternal heaving is nothing but a sign of a right ventricular hypertrophy. Right ventricle can produce a heaving here only, whereas apex, whether it's hyperdynamic or heaving, is for left ventricular hypertrophy, but parasternal heaving is for right ventricular hypertrophy. Plus or minus, you can also see epigastric pulsations. That is also a sign of right ventricular hypertrophy only. And you can see a lot of flow murmurs, especially across the pulmonary valve. Flow murmur across the pulmonary valve is again very common. Or in severe cases, you might see a pulmonary regurgitation murmur also due to pulmonary hypertension because the resistance is so high that it will try to push the blood back into the right ventricle itself. Such a high resistance. So this type of pulmonary hypertension resulting in a PR murmur, that is early diastolic murmur in the pulmonary area, is what we refer to as a classic Graham-Steels murmur. Classic Graham-Steels murmur. Clear? So other additional findings, you might have a TR, tricuspid regurgitation, that is due to again severe pulmonary hypertension where the blood, instead of moving into the pulmonary vessels because of very high pressure generated by the right ventricle, that also cannot push the blood into the pulmonary artery, but it instead pushes back into the right atrium by regurgitation into the right atrium. So that is what we call as a tricuspid regurgitation. That's called TR. That's also very common in severe case of pulmonary hypertension. Or you can get signs of right ventricular failure, like as I told you, ascites, pedal edema, hepatomegaly and jaundice, elevated JVP. Typically in pulmonary hypertension, your A wave will be prominent or A wave will be very big. That's very big A wave or a prominent A wave or a large A wave. That's what is the classic sign of a pulmonary hypertension in elevated JVP. And patients may have right ventricular S4. Remember, S4 is due to pressure overload, S3 is typically due to volume overload. In acute stages, where the right ventricle enlarges, like in acute pulmonary embolus, you can get a volume overload of the right ventricle. But in chronic stages like this, the ventricle adapts by getting thick muscles, and in pressure overload cases, you will be getting only right ventricular fourth artery only. So, you might get a RVS4 and all these things. All these are signs of, overt signs of right ventricular failure. So, these are some of the important symptoms and signs in examination that you will get in a pulmonary hypertension. So, and WHO has attempted to do a functional classification for these patients who are suffering from pulmonary hypertension. So, what are the functional classification? Typically, this applies again for type 1 only. That is the classic, but you can extrapolate all these things to the other varieties also if you are sure what the type is. But all these things are classically defined for the type 1 pulmonary hypertension only. So, what is the WHO functional class? It is nothing but it is NIHA in disguise. It's a modified NIHA classification. The same thing they would have given for pulmonary hypertension also. It's a NIHA in disguise. That's what. Which means if you learn this, it's like NIHA only. If you learn NIHA, you can learn this also. It's very simple. So, let us see the limitation. WHO class, limitation, and what is the shortness of breath in the patient and the severity. That means. So, WHO class 1 or NIHA class 1, what's going to tell is it's no limitation, which means patient is not having any shortness of breath while doing his daily day-to-day ordinary activities. NIHA class 2 means patient is having mild limitation where the patient will have shortness of breath but only at ordinary activities, but not at less than ordinary activities or not at rest. Class 3 WHO means you have moderate limitation to the patient where the patient will have shortness of breath but at less than ordinary activities. He cannot even walk a few steps. That itself will cause dyspnea, but at rest he will be comfortable. That is class 3. Class 4 is severe limitation, where the patient will have shortness of breath even at rest. So, this is class 4. So, these are the WHO functional classification for pulmonary hypertension. It is very, very similar to NIHA. There is no difference from NIHA at all. After knowing all these things, let us see some of the diagnostic points. How diagnostics will help you in achieving the diagnosis of what is the type of pulmonary hypertension, how could you probably manage that particular type of pulmonary hypertension. The first thing, let us start with the ECG, which is a very basic thing. In ECG, you will be seeing right atrial enlargement, very common sign in pulmonary hypertension. That is because blood cannot move into the pulmonary artery, which backflows into the right ventricle, which again backflows into the right atrium and elevates the JVP. Very simple. So, right atrial enlargement. So, right enlargement in the ECG will be characterized by two signs. One in lead 2, I told you will have a tall P wave. Clear? So, this is what we refer to as something called a P pulmonale. And second, in lead V1 also, it will be denoted by a large positive component compared to that of the negative component in V1. Normally, V1 should be exactly in V1, the P wave should be biphasic. That is normal. This is normal. But if you have a bigger positive component compared to the negative component, that is suggestive of a right atrial enlargement. All these things we will be discussing in cardiology section. Then you can get right axis deviation. The most important sign of a right axis deviation is in lead V1 you will get a deep S wave. That's a very, very important sign of a right axis deviation. Very, very important sign of a right axis deviation. Clear? And you might get a right bundle branch block. Again, that is due to the right axis deviation is also due to right ventricular hypertrophy, and the right bundle branch block is also due to the right ventricular hypertrophy causing strain and ischemia of the fibers, the bundle branch fibers. And finally, you can get RVH, right ventricular hypertrophy. Typically in V1, you will get a positive and big R wave. Big R in V1, typically it will be more than 7 mm. Plus, there should be no conduction delay. That is, your QRS width should be less than 120 milliseconds. But anyway, RVH is one of the very important signs in pulmonary hypertension. And again, we will see all these ECG changes in the cardiology section, why all these things are happening. And number two is the echocardiogram. Echocardiogram again is a very essential step in analyzing and diagnosing a pulmonary hypertension. The most important reason why it helps you in pulmonary hypertension diagnosis is because it gives a clue about pulmonary hypertension. Apart from that, it gives a vital clue about left heart disease. Because if it's a systolic dysfunction or diastolic dysfunction, or if it's a valvular problem or atrial defect, whatever may be the case, your echo will give a very, very vital clue. So that's why echo is very important. especially for type 2 pulmonary hypertension, this is one of the important things to discriminate. And apart from that, it will also show the pulmonary artery pressures, systolic pressures. It can also show the right ventricular pressures to an extent, and it can also show the right ventricular, right atrium and pulmonary artery size as well. So apart from showing the pulmonary artery systolic pressure, it can also show the right ventricular, right atrial and pulmonary artery size to an extent. To an extent it can show, especially the right ventricular, right atrial size you can find out through the echocardiogram. And this measurement of pulmonary artery systolic pressure PASP through echocardiogram is little bit not accurate because there can be a plus or minus 10, like up and down may be seen, but anyway, you also have to know that pulmonary artery systolic pressure can be measured through the echocardiogram. And echocardiogram also will tell you the extent of RV dysfunction by measuring something called a TAPC, where it will be less than 1.6 centimeter. We will discuss more about TAPC in the cardiology section. So right ventricular dysfunction, very, very important feature again. And in severe cases, you might also see the typical D shape of the interventricular septum and the right ventricle. D shape of the septum. So why D shape? I told you already. Normally, whenever you have a this is the left ventricle and this is the right ventricle. I told you if this is the septum here, whenever the systole happens, the septum will buckle towards the right ventricle. That is because of the high pressures generated by the left ventricle compared to the right ventricle. So if the right ventricular pressures become almost equal to that of the left ventricle, what will happen is there will be no change in the septal movement. Septum will not buckle at all. It will be remaining straight because it cannot move this side also, it cannot move this side also, because the right ventricle is now generating almost equal pressure to that of the left ventricle because of extreme pulmonary artery hypertension. So you will see this is the septum here, and you can see the right ventricle like this, so it forms a D shape. That's a D shape that's typical of a severe pulmonary hypertension. It's a very important question for exams also. These are some of the important findings in echocardiogram. Number 3, you can do a PFT, pulmonary function test, very basic again, where in pulmonary hypertension you will get one classic finding. That is, we are talking about a type 1 pulmonary hypertension. That's why I told you all these investigations will go towards a type 1 classic pulmonary artery hypertension. In type 3 and all, you might get varying results because you might have an underlying COPD or ILD. We're not talking about that. In type 1 classic pulmonary arterial hypertension, what you will get? Your spirometry will be normal. Your spirometry will be completely normal, which means entire your volumes, capacities, all these things will be normal. But there will be gross reduction of the DLCO, which means there will be disproportionate reduction of DLCO compared to that of the volume and capacity reduction. There won't be any problem in the capacities and volumes, but DLCO alone will be grossly reduced. Whenever in exam, if they tell you such a grossly reduced DLCO or disproportionate or isolated decrease in DLCO, you always think about a vascular cause, that is pulmonary hypertension as the first possibility. Especially in exam, CREST syndrome is a very, very common question where they will give entire spirometry is normal, but DLCO alone will be reduced. Go for pulmonary hypertension because of CREST syndrome. That's a common scenario in exam. Apart from that, it can happen in many other conditions like early ILD, severe anemia. A lot of conditions are there, but early ILD is one realistic possibility where in very early stages, only diffusion limitation will be there in ILD. As they move later and later in ILD, the volume changes, capacity changes will happen in spirometry, and the patient will go for altered PFTs at the same time. They'll go for restrictive lung disease kind of pattern. Clear? But this is a very, very important point. Again, but you can see an obstructive lung disease or restrictive lung disease pattern, especially if you're dealing with a type 3 pulmonary hypertension. And DLCO is highly variable. Again, depending on what lung disease you're dealing with. If you're dealing with a type 3 pulmonary hypertension. So only in type 1 pulmonary hypertension, you'll get a classic finding like this. Number 4, you can do a ABG. ABG, I told you, is going to show your type 1 respiratory failure where you'll have a low PaO2 with a low saturation. Along with it, you'll have a low PaCO2. That's a classic type 1 respiratory failure, and you'll have elevated AO2 gradient. Definitely will be more than 12. 12 is a magical number because you know very well less than 12 is the normal anion gap, less than 12 is the normal A gradient, and less than 12 is also the normal transpulmonary gradient. Clear? Type 1 respiratory failure. And fifth one, you can do a PSG, polysomnography. This is to rule out OSA. OSA is a very important cause of pulmonary hypertension, especially in obese patients and snoring patients. You can try doing a PSG, polysomnogram. And sixth one, you can do a CT. Typically, you can do two types of CT. One is called a HRCT and second one is CT pulmonary angiogram. Remember, HRCT is an integral component to diagnose a type 3 pulmonary hypertension due to lung disease. Very, very integral component. At the same time, it can also see the right ventricular and right atrial size, which will be enlarged. And it can also see to an extent the pulmonary artery size, again, which will be enlarged. So, some things you can see and very, very integral for diagnosing a type 3 pulmonary hypertension. And CTPA again is a very, very integral component for diagnosing a type 4 pulmonary hypertension. But remember, CTPA can only see large and medium vessels. To see the small vessels, always they should be coupled with VQ scan. Again, this is for type 4 pulmonary hypertension, but for seeing the small vessels, you definitely need a ventilation perfusion scan for sure. Apart from this, you can do right heart catheterization, which is supposed to be one of the important gold standards for diagnosing pre-capillary versus post-capillary. So, what will be the changes in pre-capillary and what will be the changes in the post-capillary? We already discussed. All these changes will be there. Like MPAP will be more than or equal to 25 in both. There is no doubt about that. MPAP will be more than or equal to 25. But the transpulmonary gradient here will be increased, where the transpulmonary gradient here will be normal. And finally, the PCWP will be normal here, whereas PCWP will be elevated, more than 15. But I told you pulmonary vascular resistance variable. Here, definitely the pulmonary vascular resistance will be increased, whereas pulmonary vascular resistance will be variable here. What is the importance of that? Suppose these are characteristic features of post-capillary pulmonary hypertension. With this, see the pulmonary vascular resistance, if it is normal or if it is increased. If pulmonary vascular resistance is normal, we just call it as a left heart disease causing a reactive pulmonary hypertension. That's all. It will come under just a reactive pulmonary hypertension that is due to left heart disease and congestion. But if pulmonary vascular resistance itself is increased, then you have to try and reduce PCWP and then recheck the pulmonary vascular resistance. So, which means you give some maneuvers that will reduce the PCWP. Like you can give nitrates also, which will reduce the preload to the left side. So, you can clearly do some drugs and you can use some drugs that reduce the preload to the left side, like reducing the PCWP and recheck the pulmonary vascular resistance. Now, if the pulmonary vascular resistance decreases or if pulmonary vascular resistance is still high, the pulmonary vascular resistance decreases once you reduce the PCWP. We call that as a mixed pulmonary hypertension. If the pulmonary vascular resistance is still high despite reducing the PCWP, which means it's a even more worst stage, that's a fixed pulmonary hypertension. So, you have this many types in post-capillary pulmonary hypertension itself. Just simply due to left heart disease, you might get all these problems. So, you have to know what is the type to give the treatment properly. Fine. Similarly, in pre-capillary pulmonary hypertension, again, right heart catheterization will not only help in establishing the diagnosis concretely, at the same time, it will also tell you, especially in type 1 pulmonary hypertension, whether you can give a vasodilator or not, whether it will be helpful or not. So, whether vasodilators will be helpful or not, we do something called a vasodilator challenge or vasoreactive test, or otherwise referred to as vasodilator challenge. You can call it in any way. So, where we use nitric oxide, adenosine or prostanoids, prostacyclin. So, any one of these drugs can be used to check the vasoreactive response. Suppose giving these vasodilators results in a positive test. What do you mean by positive test? Reduction in the pulmonary artery pressure by at least more than or equal to 10 millimeters of mercury. Plus, if the pulmonary artery pressure becomes less than 40 millimeters of mercury overall. So, this is considered to be the positive test. So, if they are responding to this vasodilator challenge and this criteria is fulfilled, means definitely these patients will have a long-term response to calcium channel blockers. Long-term response to calcium channel blockers. That's the idea. At the same time, they have a reasonably good prognosis. Survival will be a little bit high. Suppose if they don't react, means if the criteria is not fulfilled, which means they are not dilating in response to the vasodilator, means there will be poor response to calcium channel blockers. At the same time, this is also associated with a little bit of reduced survival and a bad prognosis. So this is the idea. So which means this NO challenge is not only helpful, or this vasculature challenge is not only helpful for assessing the disease, it's also helpful for assessing the prognosis also, treatment as well as prognosis. Similarly, your right heart catheterization will not only be helpful for making the diagnosis, it's also for making the prognostication and management decisions also. Because again, here also it's helpful in your management decisions apart from the diagnosis. That is why right heart catheterization is considered to be one of the important gold standard tests for pulmonary hypertension assessment. Now, there are a lot of miscellaneous and other investigations are there which you can do. Like you can do an LFT to rule out your portopulmonary hypertension, then HIV testing to rule out HIV-associated pulmonary hypertension. Then you can use vasculitis labs. Vasculitis tests are there, like you can do an ANA, rheumatoid factor, then your scleroderma antibodies like SCL70, anti-centromere antibodies. You can do a lot of ANCA testing. So a lot of testing you can do to rule out other causes. Vasculitis panel you can do. At the same time, there is another testing called 6-minute walking test. That's called 6MWT, 6-minute walk test. This is very, very important for assessing the functional status, because a 6-minute walking test of less than 300 meters indicates an extremely poor prognosis, because they cannot even walk for 300 meters, means the prognosis and survival is going to be very, very poor. So these are some other tests which you can try in a pulmonary hypertension patient. So I told you all the investigations and all the related diagnostic findings in pulmonary hypertension. So finally, coming to the treatment. Treatment means we are talking about a pre-capillary pulmonary hypertension, because post-capillary there is no point in me telling, because you know how to treat a post-capillary by treating the left heart disease. But in general, we need the type 1 pulmonary hypertension whose treatment is extremely specific. Because type 2, it's treating the left heart disease, type 3 it's treating the lung disease, and type 4 it is treating the patient with anticoagulation. But type 1 is very, very specific treatment are available. So that's why type 1 is what we are going to see now. That's for pre-capillary pulmonary hypertension. So what are the treatments you're going to use? First is obviously oxygen. Why oxygen? Because they reduce the hypoxic pulmonary vasoconstriction. Target saturation is to maintain more than 90 to 92%. That is the idea. Point number 2. You can use adjunctive treatments. What are the adjunctive treatments? Apart from oxygen, you can use diuretics. Remember, diuretics will reduce the preload to the right ventricle to an extent, but you have to be very cautious, because already the preload to the left side is very less. If you further reduce the preload to the right side, you might result in severe hypotension and hemodynamic collapse. So diuretics has to be used very cautiously, but still it is approved because it reduces the right ventricular strain on the right ventricle, because of more volume and more pressure only they are getting strained. So if you reduce a little bit strain, probably right ventricle may survive a little bit more, and this will help in the edema also. And digoxin, that is to hit the right ventricle and push more blood as much as possible. And next you can try agents like anticoagulation also, even though it is not routinely indicated and it is not having that much benefit as once it was thought, but still it is indicated in certain cases of type 1 pulmonary. Because certain trials prove that they can reduce the risk of thrombosis, platelet aggregation to an extent, and they can also reduce the vascular changes in the pulmonary artery that is happening in type 1 pulmonary hypertension. So to an extent, you can use anticoagulation. Then you can use inhaled nitric oxide, dobutamine. All these things are available but not routinely used. The next important treatment is going to be on the vasodilators, and this is the most important treatment in type 1 pulmonary hypertension. And the vasodilator which you are giving must be a pulmonary vasodilator, not an isolated systemic vasodilator, which is of no use. The idea of giving a vasodilator is very simple. They have to reduce the pulmonary vascular resistance, which means they can reduce the right ventricular strain. The strain means the workload on the right ventricle will be reduced because the afterload to the right ventricle is reduced. That's why. At the same time, they have to reduce the platelet aggregation also, and thrombosis and obliteration of these vessels. They have to reduce the smooth muscle proliferation, which means they have to reduce those reactive changes and fibrosis as well. So which means vascular remodeling also should be reduced. By doing all these things, these agents will improve survival. At the same time, they will reduce the dyspnea, which means the 6-minute walking test will improve. At the same time, they will improve the functional status in the WHO scale as well. So this is the idea. This is why we give the vasodilators. So what are the vasodilators available? Vasodilators, basically you have oral vasodilators and non-oral vasodilators. Originally this was the division that is done, but currently some changes are there which I will tell you. Non-oral originally means it included prostacyclins first. Non-oral, first it included prostacyclins. Typically this is what we call PGI2 and it has to be given IV. And the drug that is available is what we refer to as epoprostenol. But the problem is, since you have to administer, if you want to administer chronically, you have to put a central line and then you have to keep administering. Even in the home also you can do this. But since this is very difficult to administer, then prostanoids have come. These are nothing but prostacyclin analogs, which means you can change the route here from IV to, for example, you can give a subcutaneous route or even you can give a inhaled route. Subcutaneous route, the drug available is what we refer to as treprostinil. Remember, treprostinil is available also as IV. So it's not only like subcutaneous, but subcutaneous is commonly used, but treprostinil. And inhaled drug, you have something called a iloprost. Iloprost is an inhaled drug. But recently, many other advancements have come. We have an oral prostanoid also in the form of something called a Beraprost. This is a recent advance. And you have a prostacyclin receptor agonist also. This is not, what I'm trying to tell is, this will not be any longer we will put on non-oral compounds. These are oral compounds. These have come under oral compounds. So these are prostacyclin receptor agonists. So that drug is what we refer to as something called a Selexipag. This is also available, oral drug. So that's why these drugs will break your myth thinking that prostanoids are non-oral drugs and prostacyclins are oral drugs. These are actually newer oral drugs that are available. So these are the boon to these patients. But even though these drugs are available, but they are very costly, what I've written on the right side, the oral drugs are the ones which are going to be very cheaper. Oral drugs will come under different categories. For example, drugs that affect the endothelin receptor pathway, endothelin receptor agonists, we can call it as ETRs, endothelin receptor antagonists, endothelin receptor inhibitors or endothelin receptor antagonists. Second group of drugs that affects the nitric oxide pathway. Drugs that affect the nitric oxide pathway. Third one, drugs that are working in a different mechanism called calcium channel blocker. So these are the three group of drugs which you can, categorize. The first is the endothelin receptor antagonist, where you have to know about the basics of endothelin. You have a compound called endothelin 1. This is one of the very, very notorious endothelins and very important endothelins that is going to cause a lot of pathologic phenomena. Like for example, if they ask you which endothelin is responsible for MI, you can tell endothelin 1. Which endothelin is responsible for pulmonary artery hypertension, you can tell endothelin 1. And which endothelin is responsible for scleroderma, you can tell endothelin 1. Endothelin 1 is one of the most pathogenic among all the endothelins. So endothelin 1 is going to act on two receptors. One is called endothelin A and endothelin receptor B. And endothelin receptor A is supposed to cause vasoconstriction, whereas endothelin receptor B is supposed to cause vasodilation. So which means we need to target the endothelin A only. But initially what drugs we have found, they have targeted both endothelin A and endothelin B in a non-selective fashion, which means these are non-selective endothelin receptor inhibitors. The drugs that was originally came are bosentan and macitentan. But currently we have this selective ETA blockers, which means that's what we want to block this vasoconstriction to reduce the pulmonary vascular resistance. So this ETA blockers are available currently, that is called ambrisentan. That is called as ambrisentan. Okay, now you have certain drugs that work on the nitric oxide pathway. So let us see what is the nitric oxide pathway. You know very well, the nitric oxide diffuse into the endothelial cell, where it's going to activate the guanylate cyclase, which is going to convert GTP into cyclic GMP. This cyclic GMP is the one that is very, very important for causing vasodilation. Clear? So the cyclic GMP is actually degraded by an enzyme called phosphodiesterase 5. So that is how your inhaled nitric oxide works. Inhaled nitric oxide works by stimulating the guanylate cyclase, which means you can directly stimulate the guanylate cyclase by giving a soluble guanylate cyclase activator. Soluble guanylate cyclase stimulator or activator. That drug is what we refer to as riociguat. Riociguat is a soluble guanylate cyclase activator. Similarly, you can give a drug that can block the phosphodiesterase 5 so that it can increase the cyclic GMP. Remember, this guanylate cyclase activator is also going to increase the cyclic GMP only. So, what are the phosphodiesterase inhibitors? It is PDE5 inhibitors that can increase the cyclic GMP levels. Very simple. You have the characteristic Viagra group drug, that is sildenafil and tadalafil. Clear? So, these are the two drugs, phosphodiesterase 5 inhibitors. And similarly, calcium channel blockers, you have dihydropyridine calcium channel blockers, which are nothing but dipins. The most powerful dipin that causes pulmonary vasodilation is nifedipine. And similarly, you have non-dihydropyridine calcium channel blockers like diltiazem and verapamil. This is also available as a pulmonary vasculature vasodilating property. So, these are the important drugs that you have to know. So, you can group under your endothelin receptor antagonists, your nitric oxide pathway group of drugs, and your calcium channel blocker. Remember, in this, the nitric oxide is the one that is actually nitric oxide dependent, but this guanylate cyclase activator and the soluble guanylate cyclase activator, if you take, this riociguat is actually not nitric oxide dependent. Whether nitric oxide is present or not, it will activate the production of cyclic GMP. So, that's why it's called a non-nitric oxide dependent. Even though these are drugs that affect the nitric oxide pathway, the riociguat is one classic example of a drug which is actually not nitric oxide dependent. Even without nitric oxide, it can activate the guanylate cyclase and you can get the desired result. So, this is the idea. So, these are the important drugs that you have to know that are going to be vasodilators that will be helpful in treating pulmonary hypertension, especially the type 1 pulmonary hypertension. Clear? Now, what are the prognostic factors and how will you affect, what is the algorithm to treat these patients? First, the moment you diagnose a type 1 pulmonary artery hypertension, you are going to first treat with O2 plus or minus diuretics, plus or minus anticoagulation, plus or minus digoxin. So, O2 is the main treatment here. Plus adjunctive you can use or you may not use. Then, do a vasodilator test. Vasodilator test is responding or vasodilator test is not responding. If vasodilator test is responding, you are going to give a oral calcium channel blocker, which means I told you already they are going to respond. Long-term response will be there for a calcium channel blocker. So, you can try oral calcium channel blocker. Suppose if vasodilator testing is negative, then you have to try only other drugs that are available. What are the drugs you will try? Which means you are going to try depending on the functional class. Let us see the WHO functional class. If it's class number 2, class number 3 or WHO functional class number 4. It's very simple. Class 2 typically will try the oral drugs. That is your endothelin receptor antagonists, soluble guanylate cyclase activators, or you can try a phosphodiesterase 5 inhibitor. But class 4 you are going to try only prostacyclins or prostanoids. Prostacyclins or prostanoids, this is what you are going to try for class 4. Class 3, you can try anything. It's something in between, so you can try anything. Either oral drug or even a prostacyclin or a prostanoid. Clear? So, once oral drug is showing a very poor response, they are not responding properly, then you can try combination of oral drugs. Combination oral drugs. If combination oral drugs is also not working, then you can try prostacyclins and prostanoids. If this is also not responding, then you can try combination of oral plus prostanoids or prostacyclins. If this is also not responding, then go for palliative care. Palliative treatment. The most important palliative treatment you are going to do is the balloon atrial septostomy. Balloon atrial septostomy. This is a very important palliative treatment where we are artificially inducing an ASD. Once you induce an ASD, the blood will jump from the right side towards the left side, resulting in mixing, which means at least oxygen delivery will increase compared to the pulmonary vascular resistance you have and pulmonary hypertension you have. They feel this shunting is better, which might overall improve the oxygen. They will cause cyanosis and they will reduce the saturation, all right. But as a whole, definitely this is important for improving the oxygen delivery. So balloon atrial septostomy in end stage cases definitely improves the oxygen delivery, no doubt about that. But at the same time, they will cause reduced saturation and cyanosis because of mixing of the blood, because you are anatomically creating a shunt, right to left shunt. That's the idea. But anyway, it overall improves the oxygen delivery. To at least it's a palliative thing. But definitive means you have to go for lung transplantation. Depending on what is the pulmonary artery pressure, suppose if you are doing a balloon atrial septostomy and you are getting a typical Eisenmenger physiology, then you have to go for heart-lung transplant. But ideally, in patients who's not having Eisenmenger physiology, you can just do a lung transplant, which is more than enough. So these are some of the algorithmic approach to treatment. Suppose here you are giving oral drugs. Suppose if the oral drugs is not having sustained response, you are not getting sustained response with oral drug, oral CCB, or you are getting a poor response with oral calcium channel blocker, now you can shift to other drugs again. So this is the algorithm for treating and managing a primary pulmonary artery hypertension. Clear? Then prognosis, finally. Prognosis wise, the median survival is approximately 2 to 8 years in all types of pulmonary hypertension, especially pulmonary artery hypertension. It's just hardly 2 to 8 years of survival. This is the maximum. And the 2-year survival rate is approximately 65% and the 5-year survival rate is approximately 45%. But anyway, average survival is approximately around 2 to 8 years. Fine. So now, what are the prognostic factors or negative prognostic indicators or poor prognostic indicators? Point number 1. If the patient is having functional class 4, WHO functional class number 4, definitely poor prognosis. The patient is having signs of right ventricular failure. Patient is having rapidly progressing clinical course, or rapidly progressing symptoms, or rapidly progressing clinical course. If the 6-minute walking test shows less than 300 meter, I think I've told this point already. If the 6-minute walking test less than 300 meter, again it's a very poor prognostic state. Then if the patient is having VO2 max, that is peak oxygen consumption, that's what we call VO2 max. And we can discuss this in detail in shock segment, where you are going to discuss probably in cardiology portion. In shock, I'll be teaching all of this. What is VO2 max? That is peak oxygen consumption. If it is less than 10.4 ml per kilogram per minute. Normally, the VO2 max in a sedentary man is 35 to 40 ml per kilogram per minute, and it can vary with your exercise capacity. For example, if you are a very good athlete, it can reach up to 60-65 also. If it's less than a paltry 10.4, again the oxygen consumption is very, very poor, which means a severe pulmonary hypertension causing very poor oxygenation in the pulmonary system. That's what it means. So that's why VO2 max less than 10.4 is a very, very poor prognostic sign. Or RV dilatation or right ventricular dysfunction evidenced by a TAPSE of less than 1.6 centimeter, or if the right atrial size is more than 20, and if your cardiac index is less than 2, normal is 2.8 to 3.2, but if it's less than 2 or 2.1 according to some textbooks, the cardiac index is less than 2 liter per minute per 1.73 meter square body surface area. That's the full thing. And if you have an elevated brain natriuretic peptide, BNP or NT-proBNP, that is a sign of a severe failure. Clear? So these are the adverse or negative prognostic indicators for patients who are suffering from pulmonary hypertension, especially the type 1 pulmonary artery type of hypertension. So even though pulmonary hypertension looks very basic, this is so many things that to be understood in a case with the pulmonary hypertension, and this is also important to an extent for exams, especially this drugs part they are asking regularly, especially what are the drugs, this drugs classification which I have given, they are asking regularly again and again. Probably very high possibility of asking this Selexipag and Beraprost, which are very, very latest revolutionary advantages. So please make a note of this Beraprost and Selexipag. Apart from that, do please make a note of this selectivity of the endothelin receptor antagonist, that is ambrisentan, and please make a note of that fact that The riociguat is a soluble guanylate cyclase activator. At the same time, it is a NO independent drug. It's not dependent on NO, whether it's nitric oxide is present or not. So these are some of the important points which I want to tell. With this, I can close this pulmonary hypertension section and we can move on to a whole new area of OSA and ILD in the next section. The coming sections, that's a big topic.